So what is the disease like in Western Australia, and how does this differ from the disease that we've seen in the screening studies? To find this out, we reviewed the biopsy results of over 5,000 patients in a 6-year period, courtesy of data collected by Dr. Cohen in the West Australian prostate cancer database. This database does represent a significant proportion of biopsies done in Western Australia, accounting for over 85% of biopsies and over 98% of all radical prostatectomy specimens. This makes it a very valuable resource in order to determine the significance of the cancer within our population. In our practice, we use PSA differently to how it would be used in a screening study. Instead of using an arbitrary cutoff which determines when a biopsy would be done, the decision is made based on the total risk that we assess the patient would be at. This is done both by using PSA velocity or rate of change, and age-related reference ranges. We also look at the family history, the free-to-total ratio, and the rectal examination findings. So over a period between 1998 and 2004, there were 5,146 biopsies done in WA. The median age was 65, and the median PSA at biopsy was 8.1. These readings differ from the screening studies in that the patients are generally older and their PSAs were much higher. There would be a cutoff that would normally trigger a biopsy in a screening study. This is typically around 4. This suggests that patients generally are presenting later in their disease process than would be seen in a screening study. What we found when we looked at the PSA results for patients before their biopsies was that only a very small number were having biopsies done at around the 4 level. And in fact, almost 36% of patients didn't have their first biopsy done until the PSA was over 10. Of those patients who had a biopsy, 59% of them were found to have cancer. This is a very high reading, which is 1.6 times as high as that seen in the PLCO study, and almost twice the rate of what was seen in the ERSPC study. With patients having a repeat biopsy, 32% were found to have cancer following on from that first biopsy, giving a total positive biopsy rate for these patients of almost 63%. It's important to understand what the disease was like. It's important to see that we were diagnosing cancer at a very high rate, but was this cancer actually significant? What we found was quite surprising, in that only 28% of patients had Gleason 6 or less disease, and a combined total of over 50% of patients had Gleason 7 disease, with 20% in total of these patients having the higher grade 7 disease, comprising primary Gleason 4 disease. 19.3% of patients had Gleason disease in the 8 to 10 range. So overall, we were seeing 72% of patients with high-grade disease, which was 2.5 times higher than the ERSPC study. This shows clearly that we are seeing much more aggressive disease in Western Australia. This would also suggest that we would see a much greater benefit from screening than was seen in the ERSPC study, where there was a 20% reduction in mortality at the 9-year mark. We can see from the Gothenburg trial that this increases to around a 50% reduction in death at 14 years. If screening was commenced in Western Australia, you would expect a much higher improvement than this. So what happened to the men that we diagnosed? Is there evidence of overtreatment in Western Australia? Are all patients receiving operations, some unnecessarily? Is there widespread unnecessary surgery? And is this a cause for concern regarding a screening program? Were the cancers still significant when the pathologist was able to view a complete specimen? What were the positive surgical margin rates at surgery? Well, only approximately 28% of patients proceeded to surgery following on from a radical prostatectomy. And this is a 98% representation of all radical prostatectomies in Western Australia on Medicare data, so this is an accurate figure. Insignificant disease was seen in only 5.5% of radical prostatectomy specimens. This is much lower than would be seen in the overseas screening study populations. At surgery, the positive surgical margin rate was 27%, which is much higher than you would expect or desire. So why so few operations? Well, the major reasons were that many cancers were too advanced for surgery, as they were detected too late. Surgery is only curative as an option if the cancer is confined to what can be physically resected. If the cancer is beyond this, then radiotherapy is often used as a treatment of choice. Other reasons include the higher age, with a median age of 67 influencing some decisions not to proceed to surgery. Patient preference and surgeon preference. Not all surgeons would be comfortable operating on higher risk disease, for example, and may prefer to use radiotherapy. So in essence, we are diagnosing prostate cancer too late in WA. And prostate cancer is unlike other cancers because there is very little margin that can be taken beyond the prostate itself. Once the cancer starts to progress beyond the margins of the prostate capsule, the chance for cure reduces dramatically. Surgical success, therefore, is determined by the stage at diagnosis, and stage is purely a function of time. Therefore, early detection is the key to success with surgery. And currently this is not what is being achieved with our current approaches to PSA testing. So as a patient, what can you do? Well, the Urological Society of Australia and New Zealand currently recommends that patients have their first PSA test at the age of 40 to establish their risk of prostate cancer in the future. We don't expect that you will have prostate cancer at this age. However, if your PSA is above the median for your age, then you could be at higher risk and should be watched more closely. The best way to do this is with annual PSA tests and close documentation of the PSA levels. If the PSA is to rise more than 0.5 nanograms per mil per year, then referral for a biopsy would be indicated. Rectal examinations are still very important, and although nobody likes them, it's essential for 10 to 15% of men diagnosed with prostate cancer, as this will be their only abnormality. It may also be important to look at strategies for prevention, and thankfully these can be quite simple. Maintaining a normal body weight, remaining physically active, and having a good calcium and vitamin D intake appear to be important. Selenium and vitamin E have been shown not to be helpful in reducing the incidence of prostate cancer.